I hope you're all having a good day. So in this video, I'm going to discuss how I made the pathophysiology of two disorders, one hematologic disorder and one from reproductive disorder. I will start with hematologic disorder, so I chose sickle cell anemia. So first, let us know what is the pathophysiology. Pathophysiology, it is the physiological processes associated with the disease or injury. Now, unsa man to ang atong contents sa atong pathophysiology? Of course, first, we need to know the causes. Causes or risk factors. This is divided into two, predisposing factors and precipitating factors. I will discuss the difference between the two later on. So we need to know unsa man to para mahibaw-an nato kung unsa man to ang mga causes, risk factors in which once the child is exposed to it or the person is exposed to it, kay magkanaay changes sa iyang body. Unsa man to nga mga changes, mao na ato gitawag nga disease process. So right after the child exposed to those risk factors, mo start na ang disease process. So what changes came up? And then after those changes, unsa man ang physical manifestation, kay outward manifestation, mo na to ang ato makit-an nga signs and symptoms. Signs and symptoms sa sakit. That's the third. And then we include also kanang management and nursing management, medical management, and surgical management. Nursing interventions, kanang mga buhaton sa nurses to alleviate the pain of the patient and to improve the condition of the patient, and medical intervention as well kato mga tambal nga ihatag which is prescribed by the doctor, and then surgical intervention kato mga surgery nga buhaton if applicable sa disease. So again, what are the contents of your pathophysiology? First, you need to have the causes. Divided into two, predisposing factors, precipitating factors, disease process, signs and symptoms, and then management. Now, what are predisposing factors? Predisposing factors gani, these are factors that put the child at risk of developing the problem. Or predisposing factors, these are factors which operate from later in life and determine the person's vulnerability to the disorder. Example aniya kay mga genetics, age, race, life events. For example, for genetics, di ba inherited disorder or family history of the disease. Ang papa o mama is hypertensive. Once nga nagkaanak sila, right after the child is born, it doesn't mean nga ang baby is hypertensive dayon. But the baby has a higher chance of being hypertensive. But it may occur later in life. Number two, age. This is true to sickle cell anemia. Once the baby is born, first month, second month, third month, 4 or 5 months, dili pa mo manifest ang signs and symptoms of the child with sickle cell anemia. After 6 months pa, once the child is exposed to low oxygen. That's one example. Another example is sa age kay, example, ang otitis media. Otitis media, it is very prone lang to children from ages 6 months to 36 months, or from 4 years old to 6 years old. So, race. So, kanang dili na nato di maiwasan. It's very common to like Hispanic, Black, or Americans. And life events, for example, ato mga habits. For example, you're a smoker. If you're a smoker, you have a higher chance of getting COPD or chronic obstructive pulmonary disease. So, in short, kani mga predisposing factors, taas kayo imong chance of getting the problem once you have these predisposing factors. But it may not show, but the signs and symptoms may not show right away, or the disease process and the signs and symptoms may not show right away, but you have the higher rate of occurrence of the disease. Mga predisposing factors. For precipitating factors, these are specific events that trigger the onset of the problem, or these are events that occur shortly before the onset of disorder and appear to have induced it, or kanang nakapa-trigger sa problem. Example, trauma, infection, intoxication, physical restraints, untreated pain, exposure to an infected individual. Now, once you have these precipitating factors, mugawas tayo ang ang disease process or ang onset of the problem or ang imong signs and symptoms. So that's the difference between the two. So again, ang precipitating factors, kumbaga sa exposure to an infected individual, they mag-require a predisposing individual to exert their effect. So technically, kani precipitating factors, they do not influence the pattern of the illness. That's the difference between the two. So going back, sickle cell anemia. It is an inherited red blood cell disorder in which there aren't enough RBC to carry oxygen in the body. So before tayo ay maghimo pathophysiology, we need first to know what the disease is all about. Because we cannot really make a pathophysiology or even a schematic diagram of a pathophysiology if we don't know nothing about the disease. So we need to read usat sa book, and then we can watch videos for alternative learning para makahimo tag skeletal nga diagram for the pathophysiology. So according sa book, it is an inherited red blood cell disorder in which there aren't enough RBC to carry oxygen in the body. So it is an inherited red blood cell disorder. Inherited meaning genetic, no? So genetic, asa man to siya nagbelong, predisposing or precipitating. Naasa predisposing, no? Kaya inherited man siya. So it doesn't mean nga manifest siya dayon. So according sa book, sickle cell anemia, for hemoglobin, there are two types of hemoglobin, na abnormal and normal type. The normal type of hemoglobin is hemoglobin A. The abnormal type for hemoglobin is hemoglobin S. And always remember, ang hemoglobin S, they are very sensitive to low oxygen. And ang behavior sa hemoglobin S is maging sickle shape siya mo letter C. Kung mao ni siya ang normal, round iyang shape, ang sickle cell anemia, ang iyang buhaton sa imong red blood cells is himuan ni letter C, and then magdikit-dikit pagyud sila. Okay. Now, mo ni ako ang pathophysiology. So the first thing ang imo buhatan is to know the cause. So, mo ni siya ang cause. Inherited genes from parents or autosomal recessive disorder. This is a predisposing factor. Now, asa man nagtikang? First, kay kung ang papa, naa na siya sickle cell trait, pero this is heterozygous, meaning naa siya abnormal, naapod siya normal nga hemoglobin. Di ba ang hemoglobin A is normal, ang hemoglobin S is abnormal. Mao na ang trait sa papa. Maupod ang trait sa mama. Naa siya hemoglobin A nga normal, naapod siya hemoglobin S nga abnormal. So nagtampo sila, naa siya 50% of sickle cell heterozygous sickle cell trait. Ang mama naapod siya 50% of heterozygous sickle cell trait. Now, what happens kung magkaanak sila? There is a 25% chance of the child will get kadtong S trait sa papa ug ang S trait sa mama. So, ang child maging hemoglobin SS, which is very dangerous. Mo na siya mahimo nga homozygous sickle cell trait. Now, after 6 months of life, right after the child is born, for the first 5 months, dili pa manifest ang signs and symptoms sa bata nga naay sickle cell trait, naay homozygous sickle cell trait. It is after 6 months of life ang nganuman kinapa may fetal hemoglobin. So after 6 months, diha pa na mo regress. So, mao nga, after 6 months of life, if cells exposed to low oxygen and decreased blood viscosity, manifest na ang behavior sa sickle sa hemoglobin S. Di ba? Ang kanina, Ang hemoglobin S is very sensitive to low oxygen. Ang iyang behavior is himuon niyang letter C and magdikit-dikit sila. So that's what happened. Mo na ito ibutang next sa, di ba mo di rin nagtikang ang disease process. Then once the child is born, hemoglobin S is iyang trait, and then right after 6 months of life, if the cells is exposed to low oxygen and decreased blood viscosity, kay sensitive, since sensitive man ng hemoglobin S sa low oxygen, ang mahitabo, ang cells becomes sickled, stiff, and sticky. Magdikit-dikit sila. Once magdikit-dikit sila, what will happen? There will be stasis, which leads to local pain. For example, magdikit-dikit sila on part sa hands, ang cells sa imong hands o sa feet. Diha mag-stasis, local pain, mag-edema. And then, sickle cell crisis or onset sickling of your red blood cells. So, sudden onset nga sickling of your red blood cells, mga matay na yung red blood cells because they are weak. So, instead nga 120 days ang lifespan sa imong red blood cells, maging 10 to 20 days na lang ang lifespan sa imong red blood cells. So, mga matay sila. What will happen? Mo na po na ang next. So, blood flow halts, meaning, mararabag nag-mind map ta. So, blood flow halts, and then, when there is no blood flow, low oxygen in the body, and then the blood won't flow to the important organs in the body as well. And then the tissue becomes ischemic. And then once the tissue becomes ischemic, so wala na supportahan sa imong blood, the signs and symptoms, swelling of the hands and feet, fever, anemia, acute chest syndrome, decreased kidney function because the blood can't flow na to your kidneys, icteric eye sclera or kanong mag-yellowish, jaundice, and priapism. And that's it. So you have, and then after the signs and symptoms, remember, magkuan taog nursing management and medical management. So what are the nursing management? I included monitor hematocrit and hemoglobin levels, advise the patient to decrease physical activity because ang iyang hemoglobin is very sensitive to low oxygen. So once the body increases the demand of oxygen, mulo ang oxygen sa body. Elevate hand and feet to promote blood flow. Kaya di ba na may stasis of blood which leads to local pain. So you can advise to elevate hand and feet to promote blood flow. Adequate fluid intake to help dilute the blood. Promote bed rest since very painful man is siyang disease, and monitor respiratory status because the child is at risk with acute chest syndrome. Medical management for this, acetaminophen to relieve the pain and napod fever ang child, and then intravenous fluid replacement therapy, and then hydroxyurea to increase oxygen capacity of sickled cells, blood transfusion, kay diba na ay kuan nga magka-anemia ang bata, blood transfusion, and hematopoietic stem cell transplantation. Okay. So moro to for sickle cell anemia. In making a pathophysiology as well, just to add, you can also add more arrows if you need to, depending sa disease process. For example, sa aplastic anemia, it doesn't mean nga maghimo ra ka og usa ka arrow para kuan ba kay maging complicated. So pwede siya nimo ilahi-lahi. For example, for aplastic anemia, di ba yung precipitating factor? This is precipitating factor kan intoxication sa drugs, intoxication sa drugs, di ba? And chemicals, autoimmune response, infection. So makapatrigger sa onset nga problem. So after the child exposed to these precipitating factors, kay mo depress iyang hematopoietic activity in the bone marrow. Ibagi hematopoietic activity in the bone marrow. Once that happens, mo decrease iyang RBC, mo decrease iyang platelets, mo decrease ang WBC. So pwede siya nimo ilahi-lahi gihapon. Depending on the disease process of a certain disease. So this is applicable to aplastic anemia. So, kung decrease ang RBC, magkanay anemia, decreased RBC and hemoglobin, so tendency, decreased oxygen in the body. So, if decreased platelets, thrombocytopenia, decreased platelet formation, what will happen? So, di ba ang platelets for coagulation. If there is decreased platelet formation, the child will bruise easily bleed, PTK, epistaxis, and gastrointestinal bleeding. Decreased WBC, the leukopenia. You will WBC for kuan, protect antibody from from pathogens. So if there is decreased WBC, your body will be more susceptible to infection and respond poorly to antibiotic therapy. So, and then nursing management and medical management. So what I'm just trying to show here is pwede mo makahimo og pathophysiology adding more arrows depending sa Now, next is reproductive disorder. I chose toxic shock syndrome. What is toxic shock syndrome? It is a sudden, potentially fatal condition. It's caused by the release of toxins from an overgrowth of bacteria called Staphylococcus aureus or staph, which is found in many women's bodies. Now, let us first determine unsa man to ang mga predisposing factor and precipitating factors. Now, the predisposing factor anemia is history of using super absorbent tampons, or kung ikaw, every time nga you have your menstrual period, mag-use ka og sanitary pads nga super absorbent kaayo, and it will stay longer, it will stay for 8 hours or longer, nga dili ka mag-ilis, nga supposedly after 4 hours di ba dapat mag-ilis na. And then that's the predisposing factor. So this increases your chance of getting the disease or getting the infection. Precipitating factors katong onset. You have surgical wound, localized deep skin infection, which is a good avenue for the bacteria to proliferate in the area. Okay, now once na ay predisposing factor ngayong ani, na ay precipitating factor ngayong ani, or nabuhat ka ani niya, you have history of superabsorbent tampons na ay presence of antigen Staphylococcus aureus. And then, the antigen presenting cell or macrophages connects to multiple non-specific T-cell receptors. Now, for us to understand guys, ako explain, normally sa atong immune system, every T-cell, for example, kani ang T-cell, every T-cell has a T-cell receptor na asya T-cell receptor that has a specific binding site for only one kind of antigen. So, example lang, mo ni siya ang antigen, tas mo ni siya ang T-cell. So, one T-cell receptor can only bind with one kind of antigen. If an antigen is present, it binds to one T-cell receptor only that matches to its kind. So, for example, mo ni siya ang antigen, tapos diri siya mag-match ani niya, diha lang siya mo bind. Dili siya mo bind dire, dili siya mo bind dire. Diri lang siya mo bind kay mo ora man nag-match niya. So ang effect ana, ang T-cell mag-activate na siya of enough lang nga cytokines, releasing only specific antibody para ani niya nga antigen. Okay? So that's mo na mahitabo sa normally sa atong immune system. But with toxic shock syndrome, it's different. In the behavior of superantigen such as Staphylococcus aureus, it connects automatically to T-cell receptors of the binding sites, having specific recognition to supposedly specific antigens only. So bisag unsa pa ni siya nga kind, bisag unsa pa ni nga shape sa T-cell, superantigen man ni siya, kaya niya mo bind bisag asa. Bisag dili pa siya mumatch ani niya nga T-cell. So ang tendency kaning T-cell mo activate siya og daghan nga cytokines or massive activation of cytokines and macrophages entering sa circulation that causes the shock. So massive release of cytokines causing the shock. Now pag ma-shock na ka, mao na ang magmanifest na ang signs and symptoms. So going back, so na ay presence of antigen Staphylococcus aureus. So since dili ni siya normal nga bacteria, what happens? The antigen presenting cell connects to multiple non-specific T-cell receptors. Kay dili man siya mo recognize og T-cell. Bisag unsa ang in shape, bisag unsa nga kind nga T-cell, mo bind ra gyud siya. So ang T-cell mo react and releases cytokines all at the same time. So na ay massive activation of cytokines. And di ba kanina cytokines, ansan sila ka ng mga chemical messengers to help regulate the immune system. So tendency mo enter massive activation of cytokines, then entering the circulation, leading to shock. Now, what are the signs and symptoms of toxic shock syndrome? Magka-high temperature, vomiting, diarrhea, hypotension, severe imong muscle pain, decreased platelet count, macular rash, disorientation, and confusion. Nursing management for the signs and symptoms of toxic shock syndrome. Nursing management actually kuwang ni siya guys, but you can monitor patient's response to antibiotic therapy, assess BP, vital signs, and early signs and symptoms of shock. And since naay diarrhea, you can advise to have kanang adequate fluid intake to kanang compensate the fluid loss because of diarrhea. Increase fluid intake gihapon for hypertension to increase kanang blood volume. For vomiting, kanang small frequent feeding lang, and then bland foods like crackers. Then assist gihapon nimo ang patient to take medications like acetaminophen to relieve pain and fever. And since there is severe muscle pain, you can advise kanang promote bed rest. And then medical management, penicillinase resistant antibiotic therapy, IV fluid therapy, dopamine to increase blood pressure, and no known surgical management for this type of disorder. So I think that's it. Thank you.